Welcome to Afaxys Candid Conversations in Public Health, a new podcast series from Afaxys, a public benefit corporation serving public health clinicians and their patients. Join us as we head to the front lines of sexual and reproductive health care, bringing you timely discussions with leading experts who are shaping the future of public health.
We'll now devote some time specifically to the BV arena. And Dr. Muzny, I'd like to start with a very large level-setting question that probably could be discussed for weeks on end. But I would like to ask, from your perspective, can you comment on, is BV an STD from your perspective? Maybe you could share specifically with our audience some thoughts in this regard as to why this may or may not be the case.
Yeah, so this is a huge topic. We could definitely talk about this for hours. So in response to your question, yes, I think that BV is an STD with some caveats. When I say that, I am talking about a brand new infection of BV. I think that a lot of women have recurrent BV after they get it, and that may not necessarily always be sexually transmitted. I think BV is a polymicrobial biofilm of bacteria that forms in the vaginal canal on the mucosa. And our treatments right now have very high recurrence rates. And so women, after they get an initial case of BV, a lot of women recur. And so I think the pathogenesis of recurrent BV may not always necessarily be sexually transmitted. It may be due to our current treatments not completely eradicating the biofilm. But I do think that an initial case of BV is an STI.
Great. Thank you for distilling years of discussion into a very succinct few moments. Appreciate that. And Dr. Feldman, can you comment perhaps on the patient dialogue that you have been experiencing, around this issue specific to BV in your clinical patient care setting, and maybe even potentially from the public health customers that Afaxys serves?
Yes, this is such a common problem, as I'm sure my colleagues on the call will attest to. BV is the cause of about half of vaginitis cases that we see in a clinical setting. And the prevalence of BV in the United States is astounding. About a third of the female population has BV. About 50% of Black women have BV when you're looking for both symptomatic and asymptomatic cases. And then when you take into consideration that about half of people with BV will experience a recurrence within 12 months, what I hear from patients is frustration. This is an incredibly frustrating condition for patients to deal with. That's true in my clinic and probably every other clinic, which is why talking about treatment and prevention strategies is such an important topic.
Great. Thank you so much for that perspective. And in thinking along those lines, Dr. Muzny, we understand that there was recently a study conducted out of Australia and published earlier this year in the New England Journal of Medicine. And this study focused on male partner treatment for the prevention of recurrent BV in women. Could you share with us and our listeners some information about this study and the key outcomes from the study, in addition to the conclusions of the researchers, as well as, I know our audience would love to know your own conclusions as well?
Yeah, so this was a very exciting study that I was thrilled that it got finally published in March of 2025. This was an open label randomized controlled trial of regular couples, women and men. So to be a regular couple, they had to be together for at least 8 weeks. That's how the investigators defined the partnerships. And the woman had to have an episode of current bacterial vaginosis and be in a monogamous relationship with this regular male partner to qualify for the study. And so all women in the study received standard of care treatment for an episode of BV. and then their male partners were randomized either to combination antimicrobial therapy versus placebo or no intervention, basically. So the men who got the intervention took a combination of oral multi-dose metronidazole for 7 days, which is the first-line treatment used to treat BV in women. But they were also given topical clindamycin cream that they were to apply to their penis twice a day, both of those for 7 days. Basically, the primary outcome of this study was recurrence of BV in the female partner at a 12-week time period. So they enrolled about 170 couples in this study. The Data Safety Monitoring Board stopped it earlier, similar to some of these purpose studies that Libby was mentioning, because of high efficacy in the intervention arm. And they basically found that for women whose male partners were treated, they had a reduction in almost 3 BV recurrences, like 3 episodes of a BV recurrence per person year, basically, in this study, compared to the non-intervention group. So it was a highly efficacious study, stopped early due to efficacy, and really, at this point, really helped solidify the thought that BV could be sexually transmitted, as I was mentioning in my comment earlier. So it was a very exciting study. It got published. I got to write an editorial about it along with my colleague, Jack Sobel at Wayne State University. But we shared a large amount of enthusiasm in our editorial. We talked about the strengths of this trial, some of the implications of this trial, and it can potentially change clinical practice for women with BV. I think the main limitation of the trial that we also talked about is that they did not include casual male sex partners in this trial. And so we don't have interventional data right now about casual partners. Obviously, if you think BV is sexually transmitted, you would want to treat all male partners. But right now, the data is strongest for regular partners.
Great. Thank you. I mean, it's so timely. That data and study is literally hot off the press. And thanks for sharing the editorial as well as the information about the study. So from your perspective, how do you think that this research might inform ongoing clinical practice paradigms, within the ST setting as it relates to male partner treatment?
Yeah, so Dr. Feldman said it a little while ago. Our patients are frustrated. BV is affecting their quality of life. It's affecting the way how confident they feel about themselves. It's affecting their sexual relationships, having to go to the doctor multiple times for this problem. Women are frustrated and they want better treatments, better options. And I think that male partner treatment is going to be a big factor in a multi-interventional way that we're going to manage BV moving forward. We absolutely need to come up with better treatments for women, particularly that eradicate this BV biofilm. But I think adding in male partner treatment, particularly for regular male partners right now, is going to be a powerful intervention that we can start to offer women in the clinical setting.
Great. Thank you. It sounds like, without a doubt, significant data. Can you share with us and the audience maybe an example of how you're translating this scientific data into clinical treatment practice within your clinical practice and the public health sexual health clinics in Alabama?
Yeah, so I mentioned earlier in the call, we have an ID vaginitis clinic here at UAB. So Dr. Van Gerwen and I started that clinic about 4.5 years ago. We see a large population of women who have recurrent BV coming to this clinic. We have consistently started providing these patients with the information from this trial. And I can't speak for Dr. Van Gerwen, but I'll let her say, every single patient that I have told about the results of this trial was not shocked and basically said, I always thought this was sexually transmitted. I don't know, Libby, if you...
1,000,000%. Yeah, it's very much a thing that patients are like, this is my experience and this is what I've thought all along. And I am really excited. They're all very excited about the prospect of options that allow their partners to be a part of the equation. I think one thing that's really important about this study that I find very exciting is that they named it the Step Up trial because they intended for the men to feel empowered to be a part of the solution. Like, I think that is part of the paradigm shift, that this is not just a women's issue, that men need to be a part of taking responsibility to help the experiences that their partners are having get better with these infections. So the women I see are very excited about this option. As Christina mentioned, there's a certain patient that this is really intended for based on the data that we have right now. Someone in a monogamous relationship with a regular partner is kind of who was studied in. But I think future studies will show us a lot more about the ways that this can be used. And women are excited and we're excited.
That's terrific. Thank you for mentioning that. I'm curious, are the men stepping up in your experience?
Great.
So there have been a couple of patients that I've done this for, and the partners have been willing to do this. So I think that's really great. I'll also mention that there was a qualitative study that this team did in Australia that did the research, that did the Step Up trial. They did a qualitative study about the experiences of the partners. So like the women and their male partners, and they did interviews about, what was it like, being in this study, doing this treatment. And the men, one of the themes that came across in that qualitative work was that the men felt empowered to help their partners who were dealing with this struggle. Now, I think part of that is that these are kind of, monogamous relationships. There's this altruistic component to caring for your partner that may not exist in more casual relationships. But I think overall, it kind of gave me hope in a time where sometimes we feel a little disheartened by people doing the right thing just because it helps somebody else. But the men in the trial seemed to feel like they were happy to step up. In practice, I'm eager to see how it goes.
Great. Thank you. Within the UAB system in general, is there, a method for how to, implement this new, male partner treatment? And could you perhaps share that with our audience about how you are implementing that within your healthcare system?
Yeah, so I would love to share that. We're sort of in a gray zone right now because these data are so new in 2025. The guideline committees in the United States have not made any official statements yet on them. I do know that ACOG and the CDC are working on revising guidelines. So I'll be eager to see what those recommendations are when they come out. So we're sort of in a gray zone, but we do have this very powerful data. So Dr. Van Gerwen and I, along with some of our colleagues around the country who also have vaginitis clinics, we all feel very strong about the results of this trial. And so we have started implementing male partner treatment in our clinic since the results of this trial came out. So we've been doing this now, I guess, about 7 months because this came out in March. As Libby mentioned, we have prescribed it. So we're doing it several different ways. Ideally, we would like to do like a telehealth visit with the male partner so we can explain the medications to him, make sure he has the right instructions, and then e-prescribe it directly for him. That's our first option. Our second option is we have currently partnered with our local sexual health clinic at our county public health department, pretty much down the street from UAB. So they have written into their standing orders at their clinic the male partner treatment algorithm. So male partners can also go currently in Birmingham, Alabama, to the public health clinic to get male partner treatment. And if we have male partners of our patients that are going over there, we typically call that clinic and let them know, hey, this patient is coming and needs male partner treatment. So that's another option. The third option, which not necessarily the best option, but we have considered it occasionally in some, atypical cases, is that we actually prescribe the medicine to the female. The male does not want to come in, and she actually gets it and gives it to him. Obviously, that last option I don't think is ideal. It's not something I would do all the time. And Libby, please comment on your thoughts on that one. I think the first two options are much better.
Yeah, I think that's right, particularly because it's a multimodal kind of treatment plan for the men, and explaining, for example, the application of the topical clindamycin to the penis is a little bit more nuanced than we want to rely on a female partner to be able to do. So I prefer the telehealth or the public health clinic option in terms of treating. One thing I really like about this study as well is that the group made a lot of really good educational materials for providers, patients, pharmacists to facilitate implementation of this. It's all on their website, and I'm happy to share those as well. But it has helped us build our protocol, these materials. Though they were created in an Australian context, they're easily extrapolated to the US.
Thank you. Those are really helpful tips. And you all are certainly on the cutting edge of having this data really inform clinical practice. Dr. Feldman, maybe you could comment on how partner treatment may be more or less challenging in certain customer settings, specifically maybe from an Afaxys perspective.
Yeah, sure. I was just thinking as my colleagues were speaking that partner treatment does have some challenges, right? When I'm thinking about who the Afaxys customer base is, we have federally qualified health centers, for example, but we also have high Medicaid gynecology private practices as well. So I currently come from a private practice setting, and therefore the male partner of my patient is not my patient. I do not have an established relationship with that person. And so, for example, our federally qualified health center folks who may already have an established relationship with the partner and or can easily establish a relationship if the partner comes in for care, that's going to be a little bit more straightforward than it would be for me, for example, to coordinate care in a gynecology only practice. It's not impossible, but it just, I think, adds a new wrinkle to treatment. It would be wonderful if we could have something like expedited partner therapy in this scenario. But as you know, that varies from state to state. I don't really anticipate this being eligible for expedited partner treatment in a lot of states, unfortunately. And, there are pros and cons to that as well. But I could see where there are some logistical challenges that could, make it difficult for different clinic settings.
Great. Okay. Thank you for that perspective. Our time has literally flown by and we're at the end of our conversation. But I just wanted to, before I officially close out our time, ask if there's any comments that you'd like to make before we officially close out this episode.
Just want to thank you for the opportunity to talk about prevention. We're talking about two very different topics, HIV prevention and BV prevention, but I think in today's healthcare environment, focusing on prevention for sexual health is really important. We've done a lot of slapping band-aids onto problems, and I think prevention will help us to help people feel empowered in their sexual lives and help people stay healthier so that we don't see them on the other end of the healthcare spectrum. So I just want to highlight that prevention is the future, I think, in many different STI, sexual health, HIV spaces. So thanks for platforming that.
Great. Thank you for commenting on that. Truly a public health model. So I want to thank all three of you. I know your schedules are incredibly demanding and appreciate that you dedicated some time today to share your perspectives with our audience. Also like to thank our audience for joining us today. As you heard throughout our discussion, we'll have these incredible resources linked in the show notes. And just to let you know that next month we will be convening a follow-up discussion from this episode where we'll discuss aspects of the vaginal microbiome in STD prevention and treatment. And our expert guests will be Drs. Ina Park and Craig Cohen. So thank you all for listening. Thank you to our experts, and have a great rest of your day.
Thanks for listening to Afaxys Candid Conversations in Public Health. To learn more about our mission and resources for clinicians, visit afaxys.com. Don't forget to follow or subscribe so you never miss an episode, and we'll see you next time.